Hi. For many years, much like a lot of you here, I've worked in an acute teaching hospital. So a part of my job has been respiratory. But in more recent years, I now work at Pippa Hospital in Cambridge, which is a heart and lung transplant hospital. So we get to see a big spectrum from medical respiratory problems to the impact of surgery as well. Probably 80% of our referrals are to do with dysphagia. So there's got to be some kind of connection between dysphagia and the respiratory system. But you don't have to work in respiratory to come across those kind of conditions. So time for the deal or no deal music. Yes, okay, so do you, at the moment, on your caseload, have a patient who either has a respiratory problem, like COPD, for example, as a primary diagnosis, or do you have someone who might have a respiratory problem like asthma or bronchiectasis just lurking in the background as a comorbidity? So if you could just answer, yes, you do have someone, or no, you don't. So, from the initial slides that we had earlier, the very first questions that we had, there was only a very tiny percentage of you that worked in respiratory. Most of you worked in adult neuro. You were across from a whole spectrum, but respiratory was probably one of the smallest. But interestingly, you now all recognise that it doesn't matter what area you work in, whether it's voice, head and neck, neuro, respiratory is always lurking in the background. And perhaps that's because swallowing and respiratory are so closely connected. So this is a video fluoroscopy of a gentleman that I met 2 weeks ago. He has advanced COPD. He's on continuous oxygen via nasal cannula. He was referred to us with a right lower lobe consolidation, and they thought he had swallowing issues, and they just wanted to maybe check it out, whether it was aspirating or not. So what you'll see is there is some penetration there, it's very slight. So he's penetrating during the swallow, and he's not ejecting it. So there's a slight trace residual amount left within the laryngeal vestibule there. And this is my chicken and egg dilemma that I come across a lot. So he's at the far end of the spectrum. And in my mind, I'm thinking, oh, you know, what would have happened if we would have got him the first time we saw him? The first time that he had a flare-up of some respiratory problems, would we have noticed that he was penetrating? Is it microaspiration that's led to his chronic airway problems? Or is it because he's so breathless that he's not able to close off his airway for such a long period of time that that's leaving him vulnerable to penetration? Which is which? So, deal or no deal? Does this man with advanced COPD, it's a very black and white question, and I know most of you would prefer a third option that says, don't know, but I won't allow that. So do you think this man with advanced COPD has a dysphagia that's caused his respiratory condition because of chronic microaspiration, or do you think that his breathlessness has led to his dysphagia? Yeah, I don't know what the answer is because I don't have the power of hindsight. And the research out there suggests that lots of people with COPD do have a high incidence of penetration. And there isn't a study out there to look at these patients really early on to see what's happening with their swallows. So we can't control necessarily when these patients are going to get referred to us, but we know that there is a spectrum. So at one end of the spectrum, we've got the patients with no identified underlying progressive cause, but they're getting recurrent chest infections. If you treat those recurrent chest infections, progression is unlikely. They're probably not going to be reporting that they've got a dysphagia. It might be that perhaps they are micro-aspirating, something's going on, and maybe they're the healthy, walking, talking, silent aspirators that walk among us. and perhaps something's just tipped them over the edge and now their respiratory system's flared up. Our hope for our intervention with them is that by us identifying the problem and managing them, then perhaps we can change the trajectory of their health pathway. Perhaps we'll improve their chest status. At the other end of the spectrum, we've got those patients who have advanced disease, so they do have an identified progressive cause. They might have an underlying dysphagia. We don't know whether that's led them to this point, but they're probably going to be very breathless. They might be ventilated as well, and it might be that respiratory system that's having the impact on their swallow. So how do we manage these patients? Well, firstly, we have to understand exactly what's happening with the swallow, how breathing and swallowing interact. So just taking you back to the basics of those. So when we're breathing, we share the same structures as we do with eating and drinking. They overlap. So we breathe in through the nose, through the mouth, the air goes through the pharynx, goes through the larynx, into the trachea, through the bronchus, the bronchioles, into the alveoli. Oxygen gets transferred into the circulatory system, the waste material then goes back out, and we breathe out. But we use exactly these structures for eating and drinking too. So instead of air now entering these structures, you now have food entering the oral cavity. The nasal passage closes off to stop anything going up there. The bolus goes through the pharynx. That now open airway has to close off in order to prevent anything falling into the trachea. The food gets propelled into the esophagus, and then the airway opens up again and we can breathe again. So same structures, they overlap. It's not surprising that the neural control of these, they believe, is also shared and originates in the nuclei of the medulla. And that's key. They have to work together in synchrony for us to be able to safely swallow without putting our airway at risk. So I like this slide. So you've got the cross-section of a primate there and us. And this was actually similar to a presentation from someone at the UK SRG that really made me think about this, about what a bad design we are. And their recommendation was that really we should have two tubes, one for feeding and one for breathing. And when you look at primates and when you look at newborns or infants, in a way that's what they've got. They're nose breathers, so they have a pathway for the airway to go. And the oral cavity is completely sealed off at the back unless they swallow, in which case the airway gets protected. So they have very safe protective structures. But as we've evolved and we've developed a very advanced phonatory system so that we're awesome communicators, we've compromised that protective system, and now we have an open, very vulnerable airway. So this is an image of fees for those of you that might not have seen fees. So it's as though we're standing on the back of someone's tongue and we're looking down. You can see there's lots of secretions there. They shouldn't be there. And when I play this video, it's an example of an unprotected airway. So we give this person some milk, and you just see milk, a little drop, just drop into the airway. And that's what happens when you don't protect your airway. So watch for the drop. So we have a great system and neurologically so perfectly controlled, but that timing is essential for a safe swallow and protecting our airway. So we recognise that we've got to stop breathing in order to swallow. So at what point in the respiratory cycle does swallowing usually occur? Do you think it usually occurs in the inspiratory phase, or do you think it usually occurs in the expiratory phase? Ooh. It's the closest call we've had. Wow. Okay, right. Jury's out. So the answer is it sort of depends. So there's been lots of studies about at what point that apneic period happens during the swallow, and looking at normal, healthy adults, they found that the swallow usually occurs during the expiratory phase. So in the mid to late part of the expiratory phase, as this reading shows, and it's followed, the swallow is followed by expiration as well. And on liquids, it usually lasts between 1 to 2 seconds. So when you're having a drink, think about this, especially those that said inspiration. But this varies. So Bonnie Martin-Harris and her colleagues back in 2005 did a study looking at the coordination of breathing and swallowing across the lifespan. And she found that, as the other researchers have, that most of the time we swallow during that expiratory phase. But when you're looking at an older population, so they found from the age of 65 and onwards, there's a higher frequency of swallowing on inspiration and breathing in after the swallow. It didn't put these healthy adults at any greater risk of aspiration or penetration. But if you think that an older population, more of them are going to be breathing in at the end of the swallow, perhaps if they get an age-related illness, like a stroke or some kind of neurological event or cancer, perhaps that's going to make that group of people more susceptible to pulmonary complications. So something to bear in mind. So not only age, but behaviour, the way you eat and drink can also impact that coordination. So Dozier in 2006 looked at 70 patients, an age range of between 23 and 91, of 23 and 91, big spectrum. And they looked at sequential drinking of liquids from a cup. And they found that you're more likely to breathe in at the end of the swallow after that. Possibly common sense that you've had a longer apneic period, so your body is feeling a little bit more starved and wants to breathe in. But something to bear in mind when you're looking at your patient and asking, seeing their natural habit of drinking quickly. And a study by Bonnie Martin-Harris in '94 complements this. So they were looking at breathing and swallowing coordination, and one of the tasks they got them to do was to drink a large volume, so 100 ml through a straw, and found that they have a longer apneic period and that they're more likely to swallow on the inhalation, breathe in after the swallow. So we recognise that we've got an awesome system, but it takes a lot of precise coordination for it to work really safely. And the patients that get referred to us, well, there's an imbalance there. The respiratory or the swallow is being thrown somehow. So when these people come to us, we need to think, even if they have a respiratory problem as a primary diagnosis, or if it's something that's lurking in the background, have a think about how that respiratory issue might be affecting them. Understand the nature of the swallowing problem, the physiology of it, and how their breathing's affected, and the imbalance, so which system is impacting more on which? Is it the respiratory problem, that's their breathlessness that's causing their swallow to be worse, or perhaps their swallow, if we don't fix their swallow, they're going to get more infective presentations. So how do we get this information? I can't stress this bit enough, that it's the sitting down and talking to your patient and building a rapport with them, because it's having this long conversation and bringing out all the habits that they may have, helping them to make associations, what their sleeping behaviours might be. They might not report that they have heartburn because their GP's probably put them on some kind of reflux medication, but they might say, oh, but when I lay down at night, I cough. Now, they might not associate that with reflux, but if you're asking them about their sleeping habits, this information starts to come out, and that helps with your differential diagnosis. Looking in their mouth, have they got some kind of candida? Perhaps that's a result of them having increased usage of their Ventolin, their steroid inhalers. At this moment in time, they're in hospital. Are they having to use their inhalers more? Are they having to use nasal specs more? Are they on their nippy mask more? Helping them to pull out all this information will help guide you to how you're going to manage this person, perhaps refer them on as well. But also, don't listen too much about their reports of what their swallowing problems are, because they're not always the best judge. We've already touched on the fact that potentially these people are the silent aspirators, some of them. There's fairly inconsistent research out there looking at silent aspiration in the healthy population. It's a study by Butler in 2009 looked at people over the age of 65. And interestingly, they found almost a third of people aspirated, which is incredibly high. A lot were penetrating. But in this study, they were using fees, and they were also mucking around with a manometry catheter. So I wonder whether that might have just altered the results a little bit. Whereas Yoshikawa and Kolodny both have similar results. So they found that patients weren't aspirating, but in the older populations, more of them were penetrating. And then couple that with the fact that perhaps some of these patients might be breathing in after the swallow in that older age group. It's quite interesting to think about the two together. And then looking at how the prevalence of dysphagia in COPD is a huge range again. It's very inconsistent, somewhere between 20 and 90%. And is that because they're silently aspirating? That their self-report of their swallowing problem then isn't very reliable. And McCleskey in 2002 also felt that COPD, dysphagia in COPD, was under-recognised because the patients themselves don't recognise that they have a dysphagia. So the next key thing is the mealtime observation. I think as clinicians, we're often pushed for time, and the luxury of mealtime observations is quite limited. But when we do a mealtime observation, we're presenting them with the cup. We're telling them to take the sip. We're making sure they don't use a straw. We're very clinical and prescriptive about what we're doing, and I think that changes things a lot for patients. I think just letting the patient sit back, if you can, observe their mealtime, looking at the timing of their swallow. So Gross in 2009 and her colleagues looked at COPD and found that most of those patients breathe in after the swallow. So looking at those patients with respiratory problems, looking at the rising and falling of their chest, you don't need fancy equipment. You can just see, are they breathing in after the swallow? Are they more breathless as they progress through their meal? If they're hooked up to monitors, are those figures changing? Are their O2 saturations dropping? What kind of ventilatory support have they got? Have they got oxygen running? Have they used their nippy beforehand? Are they having to take the mask off to feed? Their behaviours, what do? Are they drinking with a straw? Seems like most people in our hospital get given a straw for some reason, even a cup of tea, whereas I don't know anyone in Costa who goes out with a straw. So looking at their behaviours, and that's the important thing about doing that mealtime observation. And then, of course, if you have those facilities, then doing an instrumental assessment, because we're looking for that silent aspiration. We know they're not very good at reporting it. Differential diagnosis is also very key, which is part of that big that case history that you're taking, and reflux being a big part of that. A lot of the patients, if you look at their drug charts, they'll be on some kind of proton pump inhibitor, omeprazole, lansoprazole, or esomeprazole, something like that. It's good to find out how often they're taking it, once a day. Are they taking it when they're meant to? But interestingly, it seems a lot of these patients get put on reflux medication by their GPs and aren't given the behavioural environmental advice, like dietary changes or raising the head of the bed. So this person is a prime example. So I went to see this man, and he's on the respiratory ward. It's our lung defence ward, and he's incredibly breathless, and he's on all these types of reflux medications. And on his bed, I don't know if you can see that, but he has 2 bottles of Tabasco sauce. And it was like I'd set it up or something. And he's having Tabasco sauce on every single meal because he likes it really spicy. And nobody's ever educated him on the fact that that kind of food could aggravate his reflux symptoms. And we find that an awful lot. So bearing reflux in mind. So this is a video of someone who came to us with Charcot-Marie tooth neuropathy. So they do have a dysphagia. It's got a slight delayed swallow, but it's not really that problematic. He was getting recurrent chest infections and reporting a burning feeling when he puts his mask on. So he's on NIPI, non-invasive ventilation. So slightly delayed swallow, but it's all right, really. But what you'll see is that he gets backflow back into his pharynx. And then what happens is at the end of his swallow, at the end of his meal, he puts his NIPI mask back on and he refluxes. And we suspect that reflux material is then getting blown back down into his lung, which is why he says he gets this burning feeling down here. Which brings us on to non-invasive ventilation and breathlessness. This is, so people that are ventilated, just thinking about type of ventilation they're on, are they having it for longer? Now they're in the acute setting, they've got this exacerbation, how much they're using it for, and how that interacts with their meal times. Do they just have it on overnight? We see lots of patients with MND and they come in for introduction of using NIPI. And just from having that overnight, they feel that their swallow is so much better during the day because their breathing is stronger, it's opened up their airways, which has an impact. So finding out how their ventilation is interacting with their swallow. So this is an interview with a lady, just to give the patient's voice of what it's like to be breathless and how it impacts her meals.
Okay, so could you tell me how long you're spending on the NIPI mask at the moment?
Well, probably about 19 to 20 hours.
Okay.
At the moment, a day.
And how long are you managing to stay off it during the day?
It varies. I managed about 2.5 hours a couple of days ago, but since then it's probably the most has been about an hour.
Okay, and is that an hour in one go?
In one
go. Fantastic.
But some days it's been a few minutes and then back on the NIPI for a little while and then back off it, you know, more little and often.
Yeah, okay. So, and how does using the NIPI and being breathless affect your eating and drinking?
It's quite difficult. I find myself unclipping the one side of the mask, putting you know, a fork full of food in, and chewing it as quickly as possible, and then putting the mask back on again for you know, a minute or two, and I keep repeating that
until you get through your meal.
I get through my meal. Otherwise, if I don't use the NIPI and I'm on the nasal cannulas, I rush it so quickly, just to get it, you know, finished as quickly as possible. The meal. Yes.
And you were explaining to me as well before about your drinks when you're having a cup of tea.
I've probably found the drinking harder than the actual eating. It's very difficult when you're short of breath to sort of have a drink as well at the same time. And I have tried doing smaller sips, which just seem to help a little bit. But it is a bit, it's coordination really. It is quite difficult.
Yeah.
Yes.
Okay. And are there any strategies that you found that help with your eating and drinking?
Well, I suppose just the sort of smaller amounts. I do use a straw. I tend to use a straw at night when I have the mask on, continuously.
Yeah. And is that because of your position?
Well, it's probably easier than
to get a straw in between
yes.
the mask than rather than take the mask right off and, and drink from the cup.
Yes.
Okay.
Yes. Yeah.
Okay. Well, thank you very much.
So you can see how being breathless and having to plan everything around taking your mask off really takes the pleasure away. So this lady doesn't have a dysphagia, but her breathing and her ventilation mode really have a huge impact on her nutrition and her quality of life with meals. So we've gathered all this information. What do we do with it? Well, a lot of the information, hopefully, if there is a dysphagia, we can manage it, we can provide therapy. There might be some things like gastro or reflux we want to refer on. There's an interesting study by Bonnie Martin-Harris looking at retraining of the swallow breathing coordination with head and neck cancer patients. Now, this hasn't been done with respiratory patients as far as I know, but what she was doing was using biofeedback to retrain the initiation of the swallow, getting patients to swallow during the expiratory phase on a mid to low lung volume. And she found that it took 6.5 sessions in order to change that behaviour, which I think is really interesting and something that I'd love to see whether that could be applied to this population of patients. And then patient education, I think, is key. We have all this information. It's our role to impart that back to our patients to enable them to make that informed decision. McKinstry in 2010 was part of a pulmonary rehab programme. She had 253 patients and she gave them an hour's education. She measured the impact, their knowledge beforehand and afterwards using a self-made questionnaire and also the SWAL-QOL, and then followed them up a month afterwards and found that just educating them about breathlessness, giving them strategies and about just the coordination of breathing and swallowing improved their or lessened the burden of dysphagia, increased their knowledge, and also reduced physical symptoms of dysphagia, which they put down to the fact that it just gave them a little bit more control because they had the knowledge. So education is key. I don't know if I can...
So you were saying about the pleasure of eating and drinking.
So I was going to play you a clip there about the lady that you'd heard earlier. And she's just feeding back about how useful it is to have that knowledge about understanding the coordination, and it just makes her feel a little bit less stressed that she's not making it up that eating and drinking is really difficult to her. So giving your patients that information is really key. So just coming back to the gentleman we saw at the beginning with the advanced COPD, we know what his respiratory problem is. We've done a video fluoroscopy on him. We know that there is a delay, there is some penetration going on. So now we can look at what can we do about it. So we found that by doing a chin tuck, significantly reduces that penetration. Now, as it was happening, it was silent, so the man doesn't have any knowledge that this is happening. And we're suspecting that perhaps this drip, drip, drip penetration might be contributing to the chest problems. So biofeedback is really key to be able to educate him and his wife as to what's happening, to be able to empower him to make a decision to change if that's what he wants to do. So we had a session with biofeedback and education with the family. And by doing so, hopefully we're empowering him to make that change with the knock-on effect that hopefully there'll be less infective exacerbations of his COPD and an improvement in his quality of life. So take-home message is build that rapport with your patients, sit down, have a long chat about their longitudinal history of their swallowing problems and all the other background noise like reflux, sleeping habits, diet, previous investigations they might have, and that will all help to feed into your management decision process. be sure that you understand the nature of the problem that they've got, that respiratory problem, and how that's interacting with the swallow, and how perhaps the swallow, if you were to change something in the swallow, would that have an impact on their respiratory disease? And using your knowledge and all the information that you gather and pull together to give back to the patient, to inform them and empower them to make a decision, which hopefully will change the trajectory of their health outcomes and also improve their quality of life. Thank you very much.